Good afternoon. Thank you to everyone who is joining us for this wonderful webinar today. I am Elaine Conville-Canny. I am from Emory University's Emory Alumni Association. I am in the Miller Ward Alumni House today, being joined remotely by Dr. Saad Omer. I am excited to bring this faculty webinar to you all to stay engaged with the wonderful work that Emory faculty is engaged in right now. Please feel free to check out our website at engage.emory.edu for recorded websites of recorded programs for our faculty previous programs. And this program is also going to be recorded, so you can listen to it. If for some reason you need to step away from your computer today, we'll have the on-demand link register sent to everybody who emails, so you can listen to it in full when you have a full time to sit down and listen to it. And with that, I am very excited to have Dr. Saad Omer join us today. He's the William Foege Professor of Global Health and Professor of Epidemiology and Pediatrics at Emory University, Schools of Public Health and Medicine. He is also affiliated with the Emory Vaccine Center. He's conducted studies in the United States, Guatemala, Kenya, Uganda, Ethiopia, India, Pakistan, Bangladesh, and South Africa. Dr. Omer's research portfolio includes clinical trials to estimate efficacy and safety of maternal and/or infant influenza, polio, measles, and vaccines, and trials to evaluate drug regimens to reduce mother-to-child transmissions of HIV. Moreover, he has conducted several studies on interventions to increase immunization coverage and demand. Dr. Omer's work has been cited in global and country-specific policy recommendations and has informed clinical practice and health legislation in several countries. He's mentored over 100 junior faculty, clinical research postdoc fellows, and PhD and undergraduate students. You may have heard Dr. Omer lately on NPR as an expert practitioner on measles vaccines, which is a very timely topic right now. And we're so glad, and thank you for taking time out of your day to share this wonderful research with us, Dr. Omer. I will hand it over to you.
Thanks. And so I'll switch to the presentation. It's my pleasure to talk about the topic that was suggested, which is like, why are measles cases rising, but also talk about what can we do about it. And so those of you who have seen, my assumption is most of you have heard the stories or read the stories around increase in measles cases. These are the data. Even if they were stretched to 2000, you would see the similar pattern in terms of really low number of cases until relatively recently. So what happened in 2000 was that the US eliminated the indigenous transmission of measles, meaning that there was no internal pockets of measles in the US. After that, what you would do is you would expect some outbreaks that would be due to cases getting introduced from outside and starting outbreaks, etc. And so that's what the definition of elimination is. And we did that in the US. But since then, things percolated okay. Things were a little bit okay until a few years ago when we had approximately 675 or 6 to be precise, 667 cases in 2014. But this year, we have exceeded that number. And so since elimination, this has been the highest number of cases recorded in the US of measles. And this has been, obviously it's only in May. And so therefore, we know that this is going to be a big year for measles. So this is a little bit concerning. But there's been a lot of discussion about vaccine hesitancy and vaccine refusals and all of that stuff. Before we start going into the reasons for why we are seeing some of this upsurge, I just want to sort of clarify a few definitions. So in terms of this is the spectrum of of demand versus actual refusal from the World Health, one of the working groups of the World Health Organizations. So it can range from refusing all vaccines to demanding all vaccines. But most parents are somewhere in the middle. So there's passive acceptance to vaccine hesitancy of varying degree, and then, as I said, active refusal. So when we talk about that, a lot of parents fall within the spectrum. And so why do we, so this is a little bit of a big picture model, and this is a conceptual model. On the horizontal axis, we have the maturity of an immunization system. And in the on the vertical axis, we have incidence or rates, etc., of disease and vaccine and vaccination rates, and so on and so forth. And so in the pre-vaccine era, when you have something which is of high importance in terms of has high disease rates, that provides a nudge and an impetus to develop a vaccine. And so that vaccine is then that vaccine starts, we start increasing vaccine coverage, and that results in a decrease in disease rates. When that happens, there comes a point where parents do not see the disease, and successive cohorts of parents have this change in mental calculus because they hear about real or hear or see real or perceived adverse events or side effects, but they don't see the disease. So there's sometimes a loss of confidence associated with this change in mental calculus, and then we start seeing these outbreaks, and there's resumption of confidence, etc., and so on and so forth. Having said that, obviously this is a conceptual model. Things don't fit exactly like this, but it holds valid that often vaccines are a victim of their own success. Within this, there are several reasons for refusal. For example, trust in public health authorities, and trust in your healthcare provider, certain values like purity, etc. People getting concerned about ingredients and so on and so forth, and perceptions regarding susceptibility against vaccine preventable diseases, and some concerns about safety. So we looked at, this analysis ended through 2015. We are now updating it. Reasons for non-vaccinations in measles cases. So all the measles cases that were reported since 2000, i.e., when the elimination happened of measles in this country through, a couple of years ago, we found that approximately 70% were due to non-medical exemptions, meaning people were refusing vaccines due to religious or philosophical reasons, not for medical reasons. So that was the composition of measles cases. And if you accounted for children who were too young to be, so this pie is for only those who were eligible for vaccines. Even if you added the second biggest group of measles cases, which is children too young to be vaccinated, this problem is still pretty salient, which becomes 43% of all cases. It's the single biggest reason for measles cases, the second one being those who were too young to be vaccinated. We also found that when we created this cumulative epidemic curve, meaning that day zero is the first day of outbreak, so we added up all the outbreaks that had happened in this period. And what we found that in the beginning of these outbreaks, we had more people who were vaccine refusers that were represented than the later parts, meaning that they're providing this critical mass of susceptibles that starts these outbreaks. But look, I talked about, these are importations, but we should be mindful of the fact that these are importations from US residents going abroad and bringing back measles, not foreign visitors or immigrants, etc. So this is data, these are data from the CDC for sort of some period. But when we looked at overall as well, what we found that in this case, this is, immunization vaccine coverage and by country, and then on the vertical axis is the average measles incidence or cases of measles. And then the size of the circle is the number of authorized and unauthorized. So the light circle is unauthorized immigrants, and then the dark circles are US bound travel. So a few things. What we found from this analysis is where people are coming from, including unauthorized immigrants, have higher rates of vaccination than the US and lower rates of incidence of measles than the US. And so that means that it's the US visitors going overseas. In fact, it's 10 times more likely that an American will visit a country of vulnerability in terms of their measles rates and immunization coverage compared to an unauthorized visitor coming to the US. So one tool that we have at our disposal as in terms of policies is school immunization requirements. They're based on state laws, they're not federal, and they have played a major role in keeping low the rates of vaccine preventable diseases. And they have three types of exemptions that are allowed. So medical, religious, and personal belief or philosophical exemptions. And so it's until recently, there were two states, but now there are three states that don't have non-medical exemptions. All states allow medical exemptions, but a few states, states allowed only medical exemptions. The rest, 47, either allow religious-only exemptions or religious and philosophical exemptions. But there's another way of looking at these exemptions to immunization mandates, which is to look at how easy it is to get these exemptions. So do you just go and print a card where you check off a box and you're good for your stay in that school district, versus you have to go through physician counseling, etc., write a letter of why you want to obtain an exemption, etc. There's some procedural effort needed. So when we looked at this, we categorized using updated US we updated data created, a scale created by the CDC, and we updated for the internet age in terms of the ease of obtaining medical exemptions. We compared it to how much effort a parent has to spend in terms of keeping their child vaccinated. This is the immunization schedule. And even in the first 12 months, in the first year of life, around 4 or 5 visits are needed to keep your child up to date on vaccination. And you're not only protecting your child, you're contributing to community protection as well. You're protecting someone else's child as well, including those who are unvaccinated. So when you have this balance of either checking off a box and opting out of vaccination versus making an effort to stay up to date, that changing in balance of convenience matters. And so this is an example from Missouri where you just check off a box and you print a form, etc. And so when we looked at it and the impacts of these laws and ease of obtaining exemption, it was not only associated with immunization rates, which I'm not showing you here, but I'm showing here actual disease rates. So these are whooping cough rates, and we found that the rates of whooping cough were 50% higher in states with easy exemptions than with difficult exemptions. So when we started looking at it, we wanted to see whether the rates were getting worse, rates of refusal were getting worse. So at that time, there was a little bit of a rise, but not that much in terms of non-medical exemptions. But when we stratified it by the types of exemptions allowed at that time, only religious versus personal beliefs, so philosophical exemptions, states were increasing in their rates of vaccine refusal and non-medical exemptions. But also, if you stratified states by non-medical exemptions, but by ease of exemption, the rise was happening almost exclusively in easy exemption policy states. So this is the bottom left states. But then we followed it up more recently, and what we found was that the religious, overall, the rates were increasing, and the religious exemption states were catching up, although the philosophical exemption states were still higher, but the religious exemptions only states were catching up. But the only states where there was no rise and relatively low rates of exemptions were difficult exemption policy states. So the idea is that if you have administrative procedures that change that balance of convenience in favor of vaccination and away from non-vaccination, when you're asking a parent to do their part by, if they're going to opt out, they at least go through some effort, because the other parents who are getting their children vaccinated and contributing to herd immunity or community protection deserve that at least you spend some effort in seeking your exemptions. So what happens when you add these requirements? So those were observational data. We looked at what's happening right now or what was happening at that time. But we had these natural experiments that were out there. So the first one was Washington State passed a law where they added educational counseling and signed form from a licensed healthcare provider in order to obtain a non-medical exemption. The law went into effect in 2011. And when we evaluated this law, we saw that there was a trend in increase in the rate of exemptions And that trend was overall reasonably stable around this line, although there were ups and downs. But after the law was passed, it became a pretty stable rate at a lower level. So there was approximately 43% reduction in 43% reduction in non-medical exemptions or vaccine refusal in that state by adding physician counseling requirement. And they gained almost a decade in terms of their rates of vaccine refusal. But the thing is, these things happen not just at the state level, and it happens very locally. So heterogeneity within a state is important in their exemption rates. And so what we found was that in Washington state, where in this year there were approximately 7% refusal rate or exemption rate, there was a lot of state county by county variability. So there was 1.2% exemption rates in Yakima County versus around 1 in 4 being exempt to one vaccine or another in Ferry County. And so when we looked at the impact of this law, we also found that these hotspots slowly developed from 1998. So the red areas are hotspots of vaccine refusals, and they continue to develop with a little bit of up and down, and they peaked around 2008, 2009, 2010, and then boom, right after the law, it didn't not only decreased the overall rates, it decreased the clustering or these hotspots. But then a few hotspots were intractable. And look at this bottom one. I'm assuming people are seeing my arrow, but if you look at the bottom one, the 2014 map of Washington state, you look at this county in red at the bottom. This is where we are seeing these outbreaks. So intractable clusters play a role. So the question arises, why do we not eliminate exemptions altogether? So there are a few reasons. First of all, obviously there's backlash and opposition. It's incredibly, even if it's the right thing to do, the lawmakers are very wary of going all out and removing all exemptions. But also, there is a little bit of concern that if we looked at states' difficulty in obtaining exemptions from non-medical region and its impact on medical exemptions. And we found that states that had easy exemption policies had lower rates of medical exemptions compared to difficult and medium exemption policies. And so the idea was that some of those parents who would normally file a non-medical exemption were finding sympathetic healthcare providers who were writing these medical exemptions. Obviously, it wasn't a total wash. The strict requirements for obtaining exemptions worked in reducing the overall rates, but it is interesting to note that there was a little bit of an offset. So that was one of the concerns, and that is one of the concerns. So we have these data this actually just came out yesterday, so it's not preliminary anymore. So actually, this one is coming out. So it is preliminary data. And what we are finding is that California had 3 laws, and they had, within which they have the law that added some physician counseling, that they cracked down on conditional entrance, which is, these are the kids where you said, my kid has started this schedule, but within that schedule, they need to complete all the doses of vaccines. So that's going to take time. So you would allow them. But what was happening was that this excuse was being abused by a lot of parents and misapplied by schools. So there was a lot of these parents were not never going to complete the dose or didn't even start the dose. They just made a promise. So they had this administrative crackdown on the conditional program, and then they had this law SB 277 that had the effect of eliminating all non-medical exemptions in California. So here, the conditional entrance was the one that went down, but not after eliminating non-medical exemptions. They started going down right after the conditional program crackdown. The personal belief exemptions were obviously eliminated, but there is a near total offset by medical exemptions and those who were overdue, essentially ignoring the law and not subject to immunization requirements, i.e. those who were homeschooling and got out of, found a way to avoid these requirements. So there's a little bit of an offset effect, but these conditional programs are useful. So the lesson is, and this was happening in areas where personal belief exemption rates were high. that this is where combined replacement mechanisms were occurring, the exact same location. So this was associated by this offset effect in communities that were not too gung-ho about vaccines. And so that means that if you take this approach where you go all out and eliminate non-medical exemptions altogether, so you don't take that, you just shut down the pressure valve altogether, parents find other loopholes, and you have a little bit of an offset in terms of your desired policy outcomes. Having said that, these laws had an impact on eliminating clusters. So these are clusters of not up-to-date vaccines, vaccination status. So they were used to be clusters in Southern California, and we hear a lot about sort of vaccine refusals in Southern California. So two things happened after these interventions. Not only the intensity of clusters went down, some of the clusters in Southern California were literally eliminated. And so that's, when things cluster, that's where the outbreaks potential increases and increases exponentially in certain cases. And so that was a useful outcome after these laws. So what do we do about it? And one of the things is to intervene at the provider level, patient provider level, because providers are still the most trusted source of vaccine information, according to our and other people's research. So this was this really interesting study conducted by colleagues in Washington State, where they recorded interviews between parents and healthcare providers, and they sort of figured out that healthcare providers were discussing the subject of vaccination using two approaches. One was the so-called participatory approach, where you're saying that, should little Johnny get vaccinated at this visit? Should we get the, what do you think about giving him vaccine? Versus a presumptive approach, meaning it's time for little Johnny to get vaccinated, meaning, phrasing it as a desired default, as a routine procedure, which it is. We know that the vaccine safety profile of routinely administered vaccines is such that you have a focus on, you have a focus on, you're justified to focus on it as a routine procedure. So what happened with this is when they approached it as a participatory procedure, the exception rates were 4%, and then if you did it as a presumptive approach, the acceptance rate was 3 and 4. So approximately 75%, or to be precise, 74% of parents accepted vaccines. Having said that, this was an observational study in the sense that obviously there is some dynamic between the healthcare provider and the patient, which makes them easy to, which enables them to use a participatory versus presumptive approach to vaccine communication. But having said that, when this was tested in a randomized trial, the difference was actually still substantial, 10 percentage point, which is huge in terms of the absolute difference in immunization rates. So what do we do in terms of vaccine laws beyond talking about these presumptive approaches in interpersonal communication in the clinic? One approach is to have parents sign a form that discusses the risk of non-vaccination. So that's true informed consent. So informed consent shouldn't come from Facebook or Twitter or Instagram or Pinterest or Reddit. It should come from justifiably authentic information. So you sign the form initial saying that you understand the risk of non-vaccination. But an even more effective way of dealing with this is an in-person counseling by a licensed healthcare provider. And that, as I said, was very effective in Washington State. Then procedures to review each request for exemption. So it shouldn't be pro forma, it shouldn't be automatic. There should be health department procedures to review requests for exemptions. Some states use a letter elaborating a reason their child should be exempt. This has been useful in terms of adding to exemption procedural difficulty, but now there are form letters available, and it has less value in terms of informed consent of parents. And then also obtain the form by specifically requesting from state or local health department versus downloading it online. If a parent who's getting their child vaccinated are going through clinic visits and contributing to protecting everyone, then I think it's reasonable for a society to ask that parents who are electing to refuse vaccines at least go through this administrative procedure, but also it should be annual renewal. Again, to stay up to date on vaccination takes multiple visits over multiple years. It's only fair to ask parents who refuse vaccines to go through annual review. So what is the legislative success of these kinds of things? So we did a review of the kinds of legislation that was proposed in the US in various states between 2009 and 2012. The picture is overall the same. Essentially, bills that were proposed, most of them, an overwhelming majority of them, were for expanding exemptions or making exemptions easier. Only, so 31 of them were to expand exemptions. 5 of them out of 36 were to restrict exemptions. So, but here's the catch: none of the laws, none of the bills that wanted to expand exemptions passed, but the ones that wanted to restrict exemptions, 3 out of 5 of them passed, because it took advocacy from physicians, from the American Academy of Pediatrics, etc., and the evidence was on their side. So there's less noise but more action in that kind of a situation. Often it is in the context of emerging outbreaks. And none of them were to eliminate non-medical exemptions altogether. So only one state that has been successful has been California, to eliminate non-medical exemptions from all vaccines, and Washington eliminated very recently only for measles, mumps and rubella vaccine. So this work that we did at Emory informed, so this is from 2012, so it's dated, but I just wanted to show it as an example. This work that we did at Emory has informed legal decisions and briefs and policy recommendations from major bodies that advocate for have recommendations in this area of vaccines and infectious diseases, and it's very gratifying to inform policy and practice through research. So another thing, a new area of research that we have is based on people's values and speaking to people's values. So we don't pretend to change people's values. It's not our place. But I think we can, if we understand people's values, we can work with their values. So there's some interesting work from evolutionary and social psychology that says that just like we have taste buds that react to different foods based on permutations and combinations of flavors, we have these moral taste buds that are almost universal, and they're universal in terms of they're universal in terms of their existence, but there are differences by populations in terms of how sensitive they are to different stimuli, and what combination of taste buds are triggered by different specific stimulus. So these are the 6 moral taste buds. Care harm, which is the most ingrained, most hardwired value. For example, this is the reason why we have altruism. This is the reason why we care for life in terms of saving lives, etc. This is the reason why we find fuzzy animals cuddly, and primates and even advanced mammals have this care harm foundation ingrained. Fairness cheating is one of the sort of value, loyalty betrayal, authority subversion, purity degradation. So it can be a very secular value and a very religious value. So both of them drive that from a very underlying value of purity degradation. For example, my body is a temple, I don't want toxic ingredients in my body, is a very secular approach to purity. But on the other hand, certain ingredients violating religious edicts, etc., is also within the purview of this moral foundation. And obviously, liberty of oppression is also a value which is differential by population, but to some extent is universally held. And so we wanted to see if vaccine decisions were moral decisions, and we did this study that came out in Nature Human Behavior, and we found that yes, there were 3 values that were associated with vaccination attitudes and behaviors, and these were purity and liberty were dictating how vaccine refusal. So if you had high purity value and liberty value, you actually were less likely to accept vaccines. And if you emphasized more on authority and so therefore you had respect for physicians and public health authority, you were more likely to accept vaccines. So refusal was associated with purity and liberty, acceptance was associated with authority, or negative versus positive attitudes. And so that means that we need to design our messages that speak to these values, and that's one of the work we are doing. And these are some of the resources I developed with UNICEF, World Health Organization, and Gavi as part of my Emory role, and then these are some of the publications that we sent out, synthesizing a lot of this work. So I'm really gratified by the fact that I have a very good team of students, mentees, both faculty and postdoctoral mentees, but students and staff as well that helped me do a lot of this work that I presented. Thank you, and I'd be happy to have questions.
Thank you so much. That's a wonderful, timely topic. We did have one question come in as it relates to state laws versus federal laws. Is there any movement to present this into a federal law for consideration?
So that's a really good question. So there has been a little bit of a push there, and I was fortunate to testify in front of the Senate Health Committee, and you can look at my written testimony, etc., as well. In my oral testimony, I briefly mentioned that and stayed away from it. But here's the reason why. We have these laws are based on a legal concept which is actually older than the Constitution, or around the time of the Constitution, which is that states have the inherent powers for public safety, etc., similar powers that you have for quarantine, etc. So these are state-based powers. So constitutionally, those haven't been taken away from the states, and so they reside within the state. So that's a very solid framework within which these mandates reside. There was a workaround proposed in the Senate a few years ago, and then a few vaccine advocates pushed for it, which said, look, we can, the way the federal government nudges states to do the right thing in certain cases, or have a policy that the federal government desires, is to link funding to having certain kinds of laws. Some of us have a little bit of a concern about that, because we know that health funding is already not a given that states will accept it. And we may end up, if one state says, or two or three or four states say, it doesn't have to be a majority of states say, look, we believe in state rights, and we don't want federal government dictating what kinds of laws we have, so we are not taking your vaccine funding. Because that's the most natural place to attach these requirements, and that's been the framework that has been proposed. So in that case, we may end up exacerbating inequities due to access if there's not enough funding, or there are gaps in funding that are associated with mandates. So I think at this time, because of our system of government, it would be more appropriate to focus on the state level policy rather than federal policy. The other thing is, often if it's federal policy, the federal government aims for a least common denominator, and so it may end up having an effect of some states that have now more stringent requirements coming down to this baseline level in 5, 6, 10 years when there's no sort of immediate threat of outbreak, and then but the underlying vulnerability is still there. So that's the reason why I think it's better to focus at the state level.
Great, thank you so much. That's a great explanation. We had another question come through as it pertains to the in-person counseling that's suggested for counseling people to decide whether or not to vaccinate. Do you have any reliable digital sources that you can recommend for people who may not have the opportunity to have a physician counseling, but someone that's reliable for them to get unbiased and clear information?
Absolutely. So there are several sources. The CDC sources are not just CDC staff vetted, they're expert vetted. So they often engage external staff as well. So the CDC sources are really helpful. The American Academy of Pediatrics have a lot of really nice resources on vaccines and all sorts of questions around vaccines, etc. So that's another source. Then the Johns Hopkins Institute for Vaccine Safety has their website doesn't look as good as the material is, so I think they should improve the layout, but don't get dissuaded by their layout. The information is very up to date and very useful, focusing on safety if people have safety questions, etc. So these are 2-3 sites that have very useful information.
Great. I think we have time for one more question, and it relates to the outbreak that's been happening in universities in Los Angeles. Do you know of any university health education that's coming out of California that other universities may adopt?
So that's a really good question. So there are overall materials that are there. That's what universities are using, but I do think there's a need for developing materials for university providers, etc. So there's outbreak control materials from CDC. There are educational materials, but there is a little bit of a gap that where you could have more more proactive and customized information and approaches to persuade that are out there in addition to outbreak control. So I talked to our student health services, et cetera, and engaged with a few others, but I think there needs to be a more systematic program for doing so.
Great, thank you so much. This is super important information, and we appreciate you taking the time to share it and to share your expertise with our alumni.
Yeah, no, my pleasure.
Thank you for everyone who's listening to this recording now or later. Please do stay engaged with the Emory Alumni Association by going to our website, engage.emory.edu. We have faculty programs in person and digital throughout the year, so please stay in touch with us and follow our faculty in their research, teaching, and practice. Thank you so much to everyone. Have a great day.
Thank you. Bye.
Bye-bye.